Okej, nu är klockan 9:30 och vi startar upp dagens Cancerforum. Och vi är jätteglada från Fokus patients sida att få välkomna alla er som är här som deltagare och alla våra medverkande. Jag tror att jag räknade till 44 medverkande idag. Och tillsammans under de här 3 dagarna, för igår hade vi första dagen med konferens om personcentrerad vård och imorgon har vi också ett transplantationsforum, så har vi över 100 medverkande. Och vi hoppas att den här dagen ska bli minst lika bra som gårdagen, för det var en riktigt bra dag har vi fått höra och det är vi väldigt glada för. Men nu ser vi fram emot att få koncentrera oss på just cancer. Några ord bara om Fokus patient för er som inte har kanske träffat på oss förut. Är att vi är en mötesplats för alla inom hälso- och sjukvård och life science. Och det innebär ju att alla ni som är här kommer från företag, från organisationer, branschorganisationer, patientorganisationer, forskare och så vidare inom hälso- och sjukvård och life science. Och vi är så extremt glada över just att få ha den här mixen, därför att vi tror på att man lär av varandra. Att det faktiskt är i mötet med andra människor som många tankar och idéer faktiskt uppstår. So very welcome today to the Cancerforum, and as a representative or a founder of Focus Patient, Penilla Gunther, I'm extremely happy to see you all here today. We have 44 speakers, I think, today, and we had a great day yesterday when we talked about person-centered care, and now we're focusing on cancer today. The whole program is from the Europe's Beating Cancer Plan and the goals from the plan. And as a member of the EU Cancer Mission Board, I'm very happy to see 2 of my colleagues from the Cancer Mission Board, as well as representatives, also the CEOs from All.Can International and also European Cancer Organizations. Soon will leave the floor to. And I really hope that we will learn and exchange ideas and knowledge together today, because Focus Patient is all about, networking, learning from each other, from life science companies, organizations, professionals in healthcare, patient organizations, and so on. So please use also the breaks to connect and to talk and to meet each other. I can also add the fact that we have people coming from, I think, if I've counted it right, approximately 10 countries. So very happy to see you, and I leave the floor to Mike.
Thanks.
It's on.
Thanks, Penilla. There we go. I'm Mike, and my mic is working, and good to be with you here, and thanks for the invitation, Penilla. I was looking at the program earlier, and also looking around today at the many faces, familiar faces we have here from around Europe, which is great to see. Also new friends from leading cancer organizations in Sweden. Great to see you here as well. I think looking at the program, Penilla, I was struck by the fact that our organization represents oncologists, nurses, pharmacists, and has patients at the heart of its governance. And that combination of organizations and people brings very many times consensus. We all have our own experience, we all have our own passion, we all have our own focus, but it's consensus that gives us power as a community. And hopefully by sharing and exchanging today, we'll be able to form new relationships, build more consensus, and do a better job for cancer patients and survivors all over Sweden and all over Europe. And there's never been a more important time to have that consensus because of Europe's Beating Cancer Plan. the EU has never invested politically or financially so much in beating cancer. And if we, the people who work in the cancer community, if we don't work together to make it a success, it will never be a success. So that's a huge responsibility that we've got, and hopefully today will be one more step along that journey in beating cancer. So thanks very much for the invitation, Penilla.
Thank you so much, Mike. And Eduardo from All.Can International, very welcome.
Thank you. Thank you very much, Penilla. I am really grateful for the invitation, for being with all of you. I am honored to be with so many committed players in the fight against cancer. We all share the same mission, which is to improve health outcomes for cancer patients and survivors. So the fact of being together, of joining forces, creating synergies, connecting the dots, is one of the most important strategic aspects that you are facilitating and you are building. So thank you very much for that. I've never been good in maths, but I'm very, very convinced that 1 + 1 makes 3. And therefore, all of us together can truly advance a number of policies which are taking place, as Mike rightly reminded us, which are taking place around Europe and beyond. The political momentum should not be slowed down, should not be interrupted. There are elections which are coming up at the European level, as you all know, in the year 2024, and the fact that the geopolitical polycrisis environment demands the attention of policymakers on multiple fronts implies also that we should be maintaining our stance, our asks, if you will, when it comes to the implementation of an important framework, policy framework, which is known as Europe's Beating Cancer Plan. So, all in all, joining forces, having this global network, this community which we all represent, working together, learning from each other, and driving the implementation of the best possible policies for people who need it, I think is a source of inspiration, and it will be certainly part of our discussions and deliberations today. Thank you.
Thank you so much, Eduardo. And we will also receive very important message from the EU Commissioner, Stella Kyriakides, who sent her greetings to all of you today. She couldn't be here because it's also World Mental Health Day, and she has an event in Brussels today. But she has sent us a message. Please.
Colleagues, friends, I'm delighted to address your important event today. It's truly heartwarming to see that you will all be spending the day discussing some of the key issues of Europe's Beating Cancer Plan, such as prevention, diagnostics, treatment, and the quality of life of persons whose lives have been touched by cancer. And on World Mental Health Day, you are rightly debating mental health issues too. Taking care of mental health is essential in preventing, treating, and recovering from physical illnesses like cancer. The number of persons surviving cancer is growing, and this is very positive to see. But it also comes with challenges for patients suffering long-term effects of their illness. We must be ready to offer them all the right mental health care and psychological support. For that, different disciplines and services must work closely together. And this is what we're making happen. Our new comprehensive approach to mental health brings 20 flagship initiatives and over 1.2 billion euros in funding. And we have already launched a European mental health training program for health and other professionals. Like our new mental health approach, Europe's Beating Cancer Plan is comprehensive, tackling cancer for prevention, to quality of life for people affected by cancer. And many of its actions also target mental health improvements. For instance, the Interspeciality Cancer Training Program focuses on patient well-being and empowerment, including mental and psychosocial support. An EU network of youth cancer survivors will improve social networking and strengthen the links between patients, their carers, survivors, and social and healthcare professionals. It will also help identify needs and challenges related to fertility preservation and family planning support. Cancer survivors also face obstacles in returning to work, and many experience unfair treatment in accessing financial services. In response, we have launched studies on cancer survivors returning to work and are in the process of developing a code of conduct on fair access to financial services for cancer survivors. And finally, we have made funding available for stakeholders from the EU for Health programme for projects on mental health challenges for cancer patients and survivors. And the deadline for submitting proposals is in 1 week, so you still have time to send in your ideas. Dear friends, I am sure plenty of such ideas will be flowing at today's event as well. And I'm equally sure and determined that Europe's Beating Cancer Plan and the comprehensive approach to mental health, we will always strive to put patients first. Thank you.
Tack så mycket thank you so much for this greetings for our conference today, and we are looking forward to a coming speaker here, Ulrika Årehed Kågström. She is the Secretary General of the Swedish Cancer Society, and a lot more, I could say. She will talk about cancer and the progress within cancer work and research at all levels, really. Or challenges, not the agenda, not the solutions so far.
Maybe some things that might be helpful.
I leave the floor to you. Very welcome.
Thank you, Penilla. It's so nice to be here. I wasn't even sure whether I should speak English or Swedish, but I will start with English and we'll see if it might be a mixed. I'll look at the watch as well. So, according to the European Commission, 40% of all cancer cases could be prevented. But if powerful measures aren't taken now, cancer cases are expected to increase by 24% until 2035. That are figures talking about Europe. And here in Sweden, we expect that in 2040, 100,000 people will be diagnosed by cancer every year, and 640,000 people will be living with a cancer diagnosis that they have received in the past 10 years. And this is more the double figure we had when I joined the Swedish Cancer Society in 2016. But it's not only the expected increase of cancer cases that worries me. What also worries me is the enormous inequities we see in cancer, both between and within countries. People who seek cancer care hit barriers at every turn. Income, education, and geographical location negatively affect care. And we also know that language barriers can be a factor. In most countries, people who have low economic status and those who live in poor or marginalized groups have a higher risk of dying from NCDs than more advantaged groups and communities. Smoking rates and consumption of unhealthy food is often higher in groups with lower socioeconomic status. But we're happy to see that Sweden often ranks very well in different surveys, as for example the OECD country report on cancer. Our healthcare system generally performs well in providing good access to high quality care. Survival following diagnosis is among the highest within the EU. However, challenges persist even in our country, providing equal access to treatment, diagnosis and care. For example, participation in the screening programs in Sweden for colorectal cancer is lower than in the EU average. There are also certain geographical differences in access, since the introduction of the program wasn't implemented simultaneously in all regions, compared to our neighboring country, Finland, where it was actually simultaneously introduced in all parts of the country at the same time. And we know in Sweden that women with lower education and lower income participate in breast cancer and cervical cancer screening to a lower extent than women with higher education or higher income. And we know that inequalities exist when it comes to providing rehabilitation. And that is one of the reasons the focus that EU now places on cancer is so important in the work to fight cancer, but also to fight inequalities. One of the countries that inspired us as well is Denmark. They've been very successful in shortening the queues to cancer care. It's led to a more equal cancer care that in the end have saved lives. It's interesting to see how they have worked with management and control to ensure time to wait for care is within the standardized care process. But there are several examples of how Europe's Beating Cancer Plan will contribute to a more equal cancer care. One example is aimed to increase exchange of information in care and research. Information and progress must be shared. Here, the European Comprehensive Cancer Centres play an important role. By jointly developing screening programs, for instance, for breast cancer in both accessibility and technology, the accuracy of diagnostics can be improved by sharing health data between member states. It can lead to great progress in seeing early patterns. Treatment can start earlier and thus increase the chance of survival. How well the targets in the European Cancer Plan are achieved depends entirely on our political decision makers. Decisions and priorities need to be agreed upon at both the European and a national level. And as mentioned earlier by Mike, it's not usual that politicians put such a high priority on healthcare issues, but it really sets the picture of how important this is for all countries and all member states in the European Union. And we need to make sure that all member states are actually ready to implement the actions from the EU's Beating Cancer Plan. But now we also need to make sure that the ambitious work that this current European Commission has started will continue during the next EU Commission, which will be elected in June next year. So all of us here, we need to make sure to engage with the European parliamentarians to further expand their knowledge and engagement. The work within the Europe's Beating Cancer Plan is too important not to be highlighted and developed during the next mandate period within the EU. The great progress of research makes me feel quite hopeful when it comes to Swedish cancer care forward. And from Cancerforum and Swedish Cancer Society, we have developed our new strategy inspired by the Europe's Beating Cancer Plan. And we will set out 4 very ambitious objectives of where we think it's possible for Sweden to be in 2030. We actually want our country to reduce the number of preventable cancer cases by 30%. We want 1/3 of all cancer cases to be detected at an earlier stage. And we want to see 80% survival rates, and we're talking about 10-year survival rates. And we want all patients to experience a good quality of life. These objectives may seem unrealistic, but they are actually not. Because if we continue investing in innovation and research, we believe it's possible. And one important tool is also the development of an updated national cancer strategy that should be a document for action. It is actually 14 years since Sweden, the Swedish cancer strategy came into being, and it's brought many extremely important advances: the establishment of the regional cancer centers in Sweden, the introduction of national care programs, standardized care pathways, just to mention a few examples. And it clearly shows how a country gained from developing strategies together, closely following up on their compliance, as is possible with the EU Speeding Cancer Plan and National Cancer Strategy with ambitions, objectives or targets. If we are to defeat cancer, we see that the whole of society needs to come together, and all the different stakeholders need to feel ownership of a common cancer strategy. Putting in place a comprehensive and ambitious cancer strategy is one of the most important political tasks of our time. But strategies are all well and good, but the best cancer treatment is the one that isn't needed, which is why prevention is so central. And we all know that WHO stated last year that overweight and obesity will overtake smoking as the single biggest risk factor for cancer in many countries. It's a frightening development, and it's easy to think that obesity is a global pandemic that doesn't really affect us in Europe or in the Nordic countries, but that's far from true. Only in our country, 1 in 5 children has overweight or obesity. That's more than the double figure looking at over the last 3 decades. Our food environment has changed. Children and young people, especially teenagers, are exposed to unhealthy food in their daily life to a large extent on social media. And if we don't stop this trend and improve eating habits, we will see many more cancer cases in the future. So how can we reverse this trend? We know that social change and regulation is what's been effective for smoking. Some of the early measures introduced in several countries were more smoke-free environments. The data also shows that we're heading in the right direction. Smoking is decreasing. So we have an obligation to create a society that actually supports health and reduces the risk of obesity starting from childhood. Finally, the global cancer burden is increasing, and we need to I would like to mention 2 examples of how we need to tackle the increasing global cancer burden. One initiative that was actually launched last year is something called the Atom Coalition. It's an initiative from the Union for International Cancer Control, inviting different stakeholders, patient organizations, the WHO, a lot of pharma companies, joining forces to give access to oncology medicines in low and lower middle income countries, but also to build capacity on how to use these oncology medicines. And we're now starting, it's a really early phase, starting to implement this in 3 low-income countries. So it's just one small initiative, but it's a starting point of how we can actually work together. Another crucial step towards ensuring equity in cancer care is universal health coverage. It's fundamental, it's about equity, and it's about fair access to health. I'm glad that world leaders last month endorsed the 2nd UN political declaration on universal health coverage, something we all take for granted living in Europe. The explicit reference to the growing burden of cancer and NCDs on communities and health systems around the world in the political declaration helps to provide a foundation for advocacy and the integration of cancer control into universal health coverage. But it's not enough. The commitments made fall far short of the measurable targets and actions needed to drive change and protect cancer patients and communities. We must improve access to health services. Many people around the world don't have access to the prevention services, treatment, care, and medicines they need and to which they are entitled as a fundamental human right. This must change, and the Union for International Cancer Control will continue to work with its members to advocate for inclusion on concrete measurable targets ahead of the next review of the universal health coverage set in 2027. To conclude, we need to continue the fight against cancer and ensure that cancer control continues to be a priority on the World Health Development Agenda. This will require contributions from all of us here today, and I really look forward to our discussions on how we can make this happen. Thank you.
Thank you so much, Ulrika. And we will have a program today that really, must have your attention. And we love motion, people in motion. That's always good. Not only your mind, but your body in motion. So for each session, there will be a keynote speaker and then a breakout session. So just to remember, the breakout sessions, the seminars in English will be in this room, and all the seminars in Swedish will be just across the hall in hela världen. The whole world is called the room, and I think it's very suitable, of course. So that's a simple rule, but after each session there will be, 1 minute's walk if you like to hear a seminar, listen to a seminar in Swedish, or if you like to stay for next one in English. So I am so proud and delighted to really welcome Elisabete Weiderpass, who is a new friend of mine. We're colleagues in the European Cancer Mission Board, and that's the only similarity, because Elisabete, you have an extraordinary background within the cancer area as also director of the World Health Organization research for cancer. So please, the floor is yours.
Thank you very much. Good morning, colleagues and friends, and I'm really delighted to be here today. And thank you, Gunilla, for inviting me and giving me the opportunity to take the floor today. And I hope my slides can be put on the... Yes. So let's see if this... Yes, so this is my title. So current state of preventive measures on cancer in the world. While my colleague and friend Ulrika gave a little bit the perspective about Sweden, I'm going to zoom out to the world to see the big picture with you. And why I'm going to do that? Because I work in this organization which is called the International Agency for Research on Cancer, which is the branch of the World Health Organization specialized in cancer research, which aims to give instruments or giving knowledge to policymakers to do politics on public health. So we are based in Lyon, France, and we are an organization of 27 participating states, and Sweden, as well as the other Nordic countries, are members of the organization. That means it's your organization doing cancer research worldwide. We work a lot with etiological research, but also with prevention research. And one of our specificities is that almost all our projects have a component in low and middle income countries, in particular in Sub-Saharan Africa, in Asia, in Latin America. We are multidisciplinary. We have people in almost all cancer specialties, preclinical and clinical as well. And we serve as the main source of knowledge for the United Nations, for the World Health Organizations, and for member states across the UN family. And we are 184 member states within the World Health Organization, comparing statistics on cancer and benchmarking against each other. So, just to make it clear, what's the difference between us, International Agency for Research on Cancer, and WHO? We don't do policies. We do the knowledge, and we give the knowledge to policymakers and to WHO, and WHO does policies. So for governments, when governments ask questions, which screening to implement, how often should be the screening, which vaccine to implement, how many doses to implement, WHO give the policy suggestions to the country. And we, IARC, does the research that bases those recommendations. So, worldwide, how is the situation today, and how is the distribution of cancer incidence mortality across the different populations in the world? Most of cases are in Asia, where also 60% of the population resides, and about 60% of all cancer deaths as well. Europe has only about 10% of the world population, but has 22, almost 23% of all cancer cases and 19% of all cancer deaths. America has 20% or almost 21% of all cancer cases, but much less mortality compared to incidence, about 14%. Latin America and Caribbean, about 8% of cancer cases and deaths, and Africa, 6% of cancer cases and 7% of cancer deaths. So the ratio incidence to mortality is quite different across different areas of the world. And as you can see in Africa, the mortality is even higher than the incidence because the fatality rate is much higher. How is this going to change in the next years? And here we did a little bit projections until 2014, and we divided countries according to the wealth using an index, which is the Human Development Index, which is a composite of 4 different factors, but that summarize the wealth of these countries. These are the poor countries. These are the medium-income countries. This is the high middle-income countries, such as Brazil, for example, and this is the very high-income countries, such as Sweden. And this is a logarithmic scale. And what we see here is that the projections from 2020 to 2040, the poorest countries are going to have an increase in incidence of about 100%, which is a lot. And these countries are not prepared to take care of this tsunami of new cases that they will have. Countries, the rich countries such as Sweden, will have an increase, but it's not that big. It is going to be, Ulrika mentioned, about 25%. We estimate about 32% by 2040. So a huge amount of the increasing total number of patients and the places in the world which are least prepared to deal with them will be most affected. So the recommendations that we came up together with WHO that are absolutely crucial are, of course, HPV vaccination, tobacco control, and alcohol control. These are the key priorities right now. In terms of mortality, we will see a very similar picture. So we are about 10 million deaths in 2020, and we are expecting to see about 6.3 million by 2040. And again, the very poor countries with the lowest Human Development Index are going to have about 100% increase, while the rich countries will have much less. It will be, but not as much as with the poorer countries. Again, a big challenge in particular particularly with low and middle income countries. And here, the priority is access to affordable healthcare as the top priority for these countries. So how many cancer deaths are avoidable? And when we make such a big question, we need to specify what we mean by that. And here we used a definition which most statistical studies does. And we define premature cancer deaths as those occurring between ages 30 and 69 years. So this is a definition that UN, the United Nations, use for premature mortality. Maybe is outdated because now the life expectancy in most countries, in the rich country world at least, is much higher than 69. But this is what we use for this study. And our conclusion is that about 5.3 million premature cancer deaths globally, about 53%, and that's a lot, can be avoided. And that would lead to 183 million avoidable years of life lost, because the deaths can also be computed about how many years that the person could be alive, and then you multiply this by all the persons that died by the age of 70. So it's a massive amount. It's absolutely massive. And which are the measures that we could take to avoid all this? Well, primary prevention, mostly primary prevention, could avoid 104 million deaths and years of life, years lost, and that would be 68% of this 53%. And the rest would be early diagnosis and early treatment. So there is a massive potential for decreasing the large burden of incidence and mortality globally by these measures. But what we know about cancer prevention, and Ulrika has already explained most of the risk factors in some detail, but I would like to go cancer by cancer with you together so that we have a clear picture. And this here is a study that we did based on UK data, but it's basically replicable for all European countries. And this is, of course, published in open access. So this figure has three parts. The first part is the potential for cancer prevention. Cancer types that we know that are between 75 and 100% preventable, 25 to 74% preventable, and less than 25% preventable. So the ones that we know that are 75 to 100%, cervix uteri up to 100%, lung up to 90%, oral cavity 90%, esophageal 90%, melanoma 75%, and the stomach 75%. Cancers between 24 and 74% preventable, colorectal, bladder, kidney, liver, uterus, pancreas, and breast. And cancers that we know are less than, with knowledge today, less than 25% preventable, ovary, leukemia, different types of leukemia, NHL, prostate, and brain. And I saw with great pleasure that we have a prostate specialist in the audience, my colleague and friend Henrik, and I'm sure he can expand this, because we know a lot about prostate cancer, but how to prevent it is still a massive challenge in Sweden and elsewhere. That's it. That's what we know today. Of course, maybe within these cancers here, there are many that we know very little today about prevention. We will discover much more in the future. But just with what we already know, if we would implement it today, the suffering of cancer would be massively decreased, the number of deaths would decrease, and the years of life lost would be massively decreased. We know a lot, so we need to basically do a much better job in communicating what we know and implementing it in policies which are effective. I also note that there is a specialist in alcohol in the audience, and is Fred Nyberg. He's sitting there, and I hope he will address the audience about alcohol. But I would like just to remind, because the public in general knows about smoking. So most people know that smoking kills half of the people who smoke, basically. But alcohol, the public's a little bit confused, and also healthcare professionals sometimes are confused, thinking erroneously that it has positive effects. It does not. It's basically harmful for everything, and in particularly for cancer. And in this study, we calculated the population attributable fraction. That means what's the percentage of cancer cases that can be explained by consumption of alcohol. And we came up with the number, which it was about 750,000 by 2020. And the cancer types: esophageal, liver, breast, colon, oral cavity, rectum, pharynx, larynx, and other types. So it's quite a lot. And then we plotted in this map, and the darkest colors are the regions of the world where most of these cancer cases occur. And you can see that the Nordic countries are not as affected as, for example, China, Russia, India, and some other countries, but are quite highly affected. So there is still a lot of work to do in limiting alcohol consumption. I think within the European Parliament, I'm very sorry to say to my colleagues, we miserably are failing on that because there is no appetite whatsoever to do a better job on alcohol control in the Parliament. We tried last year to implement a very simple obligatory labeling on alcohol bottles to warn pregnant women that they should not drink, and at European level we fail even with that very basic symbol, let alone label alcohol as a carcinogen, as we do with the cigarette packages. I think that would be a very natural thing to do, and a thing that we should do, but we have failed so far to convince the parliamentarians that. Let's see if with the next generation of parliamentarians, if we would manage. But the lobbying is absolutely massive in this sense here. Women particularly affected because there is quite a tendency, and we see in several countries, for women to drink more, and the proportion of breast cancer cases is directly attributed to that. Infections. Still a lot of cancer cases attributable to infections. We estimate about 2.2 million cancer cases worldwide. The darkest colors on the map are the regions more affected by infections. And here you can see China, Mongolia, Sub-Saharan Africa, some parts of South America, and East Africa. So which are the infections which cause most of these cancer cases? Helicobacter pylori, particularly linked with stomach cancer, human papillomavirus, for which we have at least 4 vaccine products, and a 5th is being launched on the market, hepatitis B virus, hepatitis C virus, and other agents. So if we are talking about cancer control at global level, we must talk about infections as well. A massive burden linked to infections. Good news, and this is one of the studies we did, and we published, it's already published up a few years back, but I think this is very good news, and probably Sweden will be discussing this in depth and changing the way vaccination is being done. So this is a study in India where we follow for 10 years after vaccination girls that have received 1 dose, 2 doses, or 3 doses of HPV vaccination with type 16 and 18, which are the main cause of cervical cancer. And then we looked at total antibodies and neutralization titers inducing by a single dose compared to 2 doses and 3 doses. And what I would like you to look here are these numbers here: 91%, 94%, and 94%. So basically, after 10 years of follow-up, no difference in antibody and titers after 10 years, meaning that 1 dose might be enough for at least 10 years interval. So we are now following these girls even more. Some countries have already introduced 1 dose of vaccines, such as India, and India is expanding the vaccination now to other states, and many countries are following suit. UK, for example, has already implemented 1 dose, and most likely within this year, WHO will change the recommendations from 3 to 2 to 1 dose of HPV vaccine. Why is this good news? Because vaccines there is a shortage as per today of vaccines in the market. But with only 1 dose, vaccines will be more available and more children will benefit from it, both boys and girls. We also estimate for India, which has the most of cervical cancer cases in the world in a single country are in India, and how many years it will take for India, if giving one dose vaccination, to eliminate cervical cancer as a public health challenge, and it's about 60 years. So it's not one-off. It takes decades from the day we start vaccinating the population until you reach the full effect of vaccination. So it's persistence, it's investment, it's keep doing the right thing for a very long time. Europe. Let's come back to the Europe and what is the influence of cancer research for cancer prevention in Europe and how this is affecting in the world. I hope that every one of you is very familiar with the European Code Against Cancer. Why? Because this is what we know as a fact can decrease cancer incidence and mortality in Europe today. It's 12 recommendations, basic recommendations on tobacco, on alcohol, on physical activity, on weight control, on diet, on occupational exposures, on breastfeeding, on vaccination and screening. And on environmental exposures that we know as a fact that if implemented will decrease cancer burden. This has been developed in Europe for several years ago now, and IARC is coordinating this work. We are in the 5th edition. We are going to launch the 5th edition now. It's basically an interactive database with all the scientific literature summarized according to cancer prevention actions and what is or not evidence-based. So it's a very rich database. We have been expanding this to other regions of the world. We are launching the Latin American Code Against Cancer next week in Washington with PAHO, which is specificities for Latin American exposures. We are doing the same to Asia, that has very specific risk factors for Africa, and we are working in a World Code Against Cancer, which will be a massive database compiling absolutely all the evidence which is worth knowing and reading about cancer prevention. And there are several non-governmental organizations that are working with us to disseminate this, and we hope that within this decade, 80% of the European population will be aware of this code and will be able to interpret and apply it if they so wish. Costs of cancer. Absolutely massive. And we just listed here for year 2018, the total costs for Europe, almost 200 billion. And these are direct costs in health expenditure, is about half of that, and other healthcare costs, about 26 billion. And then indirect costs with, for example, productivity loss from premature mortality and morbidity, and all what it represents in terms of expenditure, which is over 5%. We also calculate in terms of GDP is about 0.5%, between 0.5% and 1%, depends on the country, it varies. So it's a massive cost. So there is most definitely a case for investment in cancer prevention. And I hope I will be discussing this further with Ulrika tonight, how we can, together with Sweden, have a more impact and more knowledge about the costs of cancer for society in the European Parliament and elsewhere. Globally, 1.2 trillion and 25 trillion if we sum up from year 2020 to 2050. So absolutely massive. How this distributes per capita according to different European countries, there is quite a lot of variation. And there are countries which are clearly not investing enough in terms of prevention and treatment. But as general, if we should simplify the story, a lot is spending on care, in particularly end-of-life care in terms of medicines, which are not that effective, in fact. They increase a little bit survival, but not that much. And relatively little is being invested in prevention and early detection. So the balance between chemotherapy and other therapies or early detection that would be prevention, which would be far more cost-effective and save far more lives, is simply wrong at the European level and elsewhere as well. A few take-home messages so that we also have a little bit time for dialogue if you so wish. So cancer incidence and mortality differ markedly across countries. And the poorest of the poor within each country, the low privileged people, the least educated, and also if you compare countries, the poorest countries are the ones with more burden. And there is a need to target these populations and countries specifically to address that. The greatest increases in incidence and mortality up to 40, and likely beyond, will occur in low resource settings. Inequalities will increase, they are increasing, and we have documented this quite clearly, and we need to address these inequalities. Access to appropriate, affordable treatment is also crucial in all countries, but in particularly in low and middle-income countries. And this is a political matter. This is a matter that we need to work with parliaments and with governments across the world to have targeted specific actions to address the needs of specifically poor populations. And efforts to plan, implement, and evaluate prevention programs must be considered as great priorities all over the world, but in particularly in low and middle-income countries. And I give the floor back to Gunilla if you wish to discuss or to address questions now. Thank you, Gunilla, for
Thank you so much. And I think we have to leave the discussions for the breakout sessions now. So everybody on the move, really. The ones who like to listen to the English seminar, please stay. The ones who would like to listen in Swedish, please go ahead to Hela Världen. And after that, it will be a coffee break. So we have some time left. But please, we'll start as soon as possible. Thank you.